Order! Order! You are an incorrigible delinquent at times. Behave yourself, man!
Now, though, doctors have produced a list of more than 40 medical treatments and procedures which they say offer little or no benefit to patients. We can talk to Dr. Alan Fayaz, who's a specialist registrar in anaesthetics and chronic pain, and also joining us from his surgery in West London is Dr. Pritpal Ruprai, a GP. Well, let's go through some of the treatments. Number one, women over 45 do not need a blood test to diagnose the menopause. Number two, X-rays are no real help to those with lower back pain. Number three, children with bronchiolitis or breathing problems usually get better without treatment. Number four, chemotherapy may be used to relieve symptoms of terminal cancer, but it cannot cure the disease and may well bring further distress in the final months of life. And number five, electronic monitoring of a baby's heart is only needed during labour if the mother has a higher than normal risk of complications. Well, that's 5 out of 40. Alan, what do you make of this list?
So, consultant in chronic pain, if I can. I think it's important to highlight interventions that are the standard or the norm, that are of questionable benefit in a minority, but actually may come with potential repercussions in the majority if applied unnecessarily. So, individually, a lot of those, for example, I deal with a lot of patients with chronic back pain, and we know that X-rays and to an extent MRI scans aren't always beneficial in these patients in the diagnostic procedure, and certainly quite often don't result in any major changes in terms of how we manage them.
Is there an element, though, with some of these of reassuring a patient who wants to feel something is being done and that it potentially does rule out something else?
So I think the question of reassurance is a very important one, and especially when it seems to be the gold standard. For example, again, coming back to chronic pain, which is a long-standing condition, I think we need to challenge how we reassure patients and really start not doing things that are unnecessary. And the evidence is that X-rays don't improve your ability to pick up unnecessary or important diagnoses, when actually specific questions can allow you to do that.
Pritpal, in your surgery, do patients come in with an idea of what they want you to do, or where is the pressure coming from for some of these things?
I mean, people are a lot more informed now than they used to be with Google, etc. And people often come with a list of investigations that they feel that they need for the conditions. For example, women who are feeling they're having menopausal symptoms, they often do come in and ask for a blood test, but often a short conversation explaining why blood tests are necessary in those kind of situations. Often, you're met with a rational kind of reaction by the patient, and they understand and they're happy to kind of go away with the information that you've offered them. There's very, very kind of few opportunities where a tense situation can arise if someone doesn't quite understand why we're maybe not doing the tests or the investigations that they were perhaps hoping for initially.
Do you ever embark on a course of action with a patient that you do feel is going to be a waste of money, but you're doing it for reassurance purposes?
I think it's important. This list is especially important at this stage. Complaints against doctors and health trusts are through the roof at the moment. Medical indemnity fees for GPs especially are extortionate. There's always this cloud hanging over us of the impending complaint if we don't actually comply with everything that the patient asks us to do. But I think we need to try and move away from that kind of defensive, compliant way of handling kind of these kind of complicated situations. And I mean, occasionally you can hypothesize with a patient that if you were to go down this route, the investigation would be done, but it may not actually help improve their outcomes or actually get you any closer to the truth. And often it's, like I said, met with a rational response from the patient, so it can be helpful. But in the past, there are been situations where arguments have ensued with patients just looking for an antibiotic prescription for the, that ongoing viral cough that they've had. And sometimes, prescriptions are done for things like antibiotics, but with the advice that perhaps they're better off not taking them for that short while and just seeing how things go. So these are pressures that we have to deal with on a daily basis.
Alan, do you think that there is an element of it being a defensive form of practicing because of concerns over negligence?
There are always concerns over negligence, but actually the evidence is that these, the 5 that you've listed here, don't improve patient safety. So I think omitting these in most circumstances, doesn't predispose doctors to harms of negligence. But I think the wider perspective, moving away from the kind of cost-benefit analysis of it and also the litigation analysis of it, is that this opens up a discussion between patients and their doctors about what not just the final treatment is, or what the steps involved to get to that final treatment are. And I think that's very healthy.
Thank you both very much. Thank you.